Good afternoon. Good to see everybody. My name is Rob DuPont with MUSC Health. I have the privilege to introduce our keynote speaker, and happy to do so. Definitely looking forward to this presentation. I'm glad everyone can be here to enjoy it as well. So our keynote speaker is Dr. Baron Short. He's a professor in the Department of Psychiatry and the Department of Medicine at the Medical University of South Carolina. He completed a combined residency in psychiatry and internal medicine, graduated in 2006, and became faculty at that time as an assistant professor with dual appointments in both internal medicine and in psychiatry. And in 2009, that wasn't enough education, went on and got his master's of science in clinical research with a focus on especially transcranial magnetic stimulation, which is largely what he'll be speaking about today as well. And also, since 2010, he has served as the medical director for our brainstem service at MUSC. An academic clinician and investigator, Dr. Short applies a range of neuropsychiatric disorders. He applies a range of neurostim strategies for neuropsychiatric disorders. There's a whole range there. It's ECT, TMS, VNS, DBS, all things that I won't explain. He's going to get into those. There's a whole range of things that can be done. Through that research, he's particularly focused on treatment-resistant depression, obsessive-compulsive disorders, and tobacco addiction. So a wide range of treatments and a wide range of disorders that are being treated. Over the past 2 decades at MUSC, he has served as a PI and also a co-investigator in over 49 completed or ongoing projects, has 65 peer-reviewed publications. In addition to all that work, he also spends a lot of time training residents as well as attending physicians in all of these treatments for brain stimulation therapies. Also is a co-founder of the first brainstem fellowship in the country, and there's only 14 that exist right now, so a very limited amount, and I was a founder in that work as well. More recently, in 2024, was the first and part of that team to implement SAINT, which is an updated type of TMS, which uses accelerated form and uses MRI for treatment that way. Reporting very successful evidence there, up to 79% remission for depression within 5 days. Unheard of, amazing work that he is helping to pioneer and to do. So clearly lots of experience in this field, so happy to have him be speaking about this. But the experience and all that he's done is only part of the reason why it's important to have him here as the keynote. It's hard to find someone who has more passion for this work and more compassion for the patients and the population of people that he serves. He sees this as not just, this isn't work, this is a mission to save lives, and he's really driving that mission and doing that every day, and happy to have him share more about that with all of you. So welcome, Dr. Baron Short.
Rob, you're a little taller than me. I gotta scoot this down a little bit. How's everybody doing this afternoon? Yeah, I'm really excited to be here with you guys. Really thankful to be here. I got this trait from my dad that he would cry when he saw beauty or love or kindness. And there will probably be some moments, I'm going to try not to cry too much. Maybe I'll make it all the way through, but probably not. So just give you a heads up, I'm okay, right? If you're like, is he okay? As Rob said, I have a lot of passion for this. This is a mission. It's not a job. I did want to say thank you. Where's Lynn? There you are. Thank you for being an angel. And thank you for taking your pain, it's already started, taking your pain and transforming it into something beautiful for this world. because that's what we're here to do, to transform her pain. I also want to say thank you to our MUSC crew, the Leatherman Pavilion. I don't know if you guys have seen it. I've been in psychiatry for a long time. I'm just going to say it because I think it's real. It's probably like the nicest behavioral health facility in South Carolina. Like, no joke. It is super nice and everything under one roof. So I don't know if y'all realize like what a gym you guys have in your backyard. It's pretty amazing, right? Shane and I were talking about that. And what you guys are doing with your community and the type of support you guys are building, I mean, unbelievable. It blows my mind. So I want kudos to you guys. I'm going to be talking about some sciencey stuff. I'm going to talk about, as I have on the slide, the biopsychosocial, spiritual aspects. I will say that I'm aware of these things because they've happened to me. And I think it's important for people to break this mental health stigma. Do a podcast with a guy, Chip Judd, on mental health in the church. And depression can be like a hell. And so there is a dissension and then there is an ascension as we kind of rebuild. So part of what we'll be talking about is how to rebuild the biology and then go back to the mind and our social networks, and then our ultimate orientation, our spiritual existential orientation. Okay, probably enough for the first slide. We only have 79 more to go. I'm not even teasing. All right. I did want to mention I'm also a co-founder with a type of technology we actually call Zendo that I won't be talking about today, but it is a health and wellness device. It's not a medical device, but we studied it actually at MUSC to enhance mindfulness states and kind of induce a focused flow state, and something I've used for about 10 years. I'm a big fan, but I won't be talking about that today. We got some more potent tools to talk about. Next slide. Yeah, there we go. I did want to do a shout out to Dr. Amen. What you're going to hear from me is more about the stimulation tools, but he was bright enough to say, let's take a look and see. And that is still, it's what you will see and what I'm talking about is some advancements of how to do that, and then what we do based on what we see. But our field in psychiatry, I'm in many ways a critic of my own field, that we need to advance what we're doing, both biologically and these other layers of our being. So I did want to give a shout out to him for doing that. Next slide. I'm going to build up the story to this slide, which is essentially where we can take functional MRI imaging and we can scan people's brain and we can run it through AI machine learning for 8 hours, and find the specific circuit to treat somebody's brain for depression and give them 5 days of treatment. And by day 5, 79% of people no longer meet criteria for depression. This is kind of like a miracle. It's actually called SAINT, by the way, too. So we'll be talking more about that. Next slide. So first, to just kind of point out that the biological reality of where we are with medications. This is an inconvenient truth that's not talked about in psychiatry, even in my own colleagues. When somebody tries an antidepressant medication for major depressive disorder, up to 36% of people get well with that. I think a lot of people think it's higher than that, but it's not. And then you try the next medicine, and maybe another 30% get better. And then after that, it drops off. Then another 13% get better. By the fourth or fifth medicine, you're getting down to about a 7% chance that somebody will get out of depression. And I have people who come see me and see our team at MUSC and say, why didn't my doctor tell me about this sooner? These treatments that I'm going to talk with you guys about. I also want to put a shout out to our Leatherman Clinic that our goal within the next year is to have some of this technology here available for you guys locally. So I want you to get excited about that. Also want to say some of the stuff I may talk about sounds kind of wild or strange, but a lot of it's local. A lot of it comes out of stuff done here in South Carolina. A lot of the things that you're going to see are things that professors they've carried out the work here in South Carolina that people are now doing all over the world. So, it's a little feel local about this. This is like really cool that we're, advancing the field around the world here in South Carolina. So, we want to break the medication loop. And if I'm kind of phasing in or out, let me know. We want to break that loop and break that paradigm. That's part of the 20th century, and we're in the 21st century. It's time to trying to change it up. Next slide. So the brutal fact is about 1 in 5 adults will have major depression at some point in their life. At least half, if not more, don't get full remission with conventional therapies. And at least 30% of people are left with treatment-resistant depression. That's a big deal. There was a Lancet study in 2015 said people with severe major depressive disorder, the level of disability and burden on them was the equivalent of having stage 4 cancer untreated. It's agony, right? Do you guys know that agony? Does anybody have raise your hand if a family or friend ever had like bad depression or a neuropsychiatric illness? Yeah. Anybody lost somebody from one of these illnesses, right? And you don't have to do this one, but has anybody dealt with it themselves? Yeah, so it's time we talk about this. Next slide. And we don't just have to appeal to our hearts. We could also talk about our wallets. This is expensive. $210 billion just on depression. I think I saw a stat in like 2030, it's going to be more like double that or something. Like this is a conservative number. And again, we know that a third of people just aren't getting well, and they are expensive, and they're in and out of the ER. They're not working. Their families are withering away. Their community is withering because people are sick, right? Next slide. So we can do different. And I think part of it is changing how we view this condition and then looking at what are the treatments at those different layers of our being. So we're not just brains and we're not just material beings. We are multidimensional. We have biology, right? We have a mind, we have psychology, we have our interconnection with each other, and we have our ultimate orientation to life and reality, to our spiritual existential understanding. And I really have just adamantly say it's so important we treat all those levels of our being. Next slide. When people have severe major depressive disorder, I think it's really important to get on the biology first. It's really, I think the people here in the room know this, but sometimes people in the community don't know. When if somebody has severe depression and you just say, get over it, go take a walk. Even a church could accidentally, unintendedly cause a problem. Say, just pray on it. Just pray is the key. And the reminder is that if you had a broken arm and a bone was sticking out, you should pray about it and you should have surgery, right? Right? And what I'm going to try to appeal to you is this is no different. It's like if the brain gets sick, it's okay to fix it, get it better, And then these other dimensions of our being to be addressed. Next slide. Yeah, I think this is a little tricky slide. So part of what we think about what's happening in the brain with major depressive disorder, I think on the other slide I mentioned, or I didn't mention, but it was on the image there, like your genetics, inflammation, your sleep-wake cycles, what you eat, all that like affects it. But then what is it affecting? And it's affecting the circuitry of the brain. And so this teal green colored image that shows this prefrontal cortex right here in the front. I like to think of it as the governor of the brain. And in depression, the governor of the brain is offline. It's not working well. Hit the next little click. And so what that will cause is some of these other brain regions like our amygdala, which is involved with arousal and fear and urgent action, or our hippocampus, which is involved with memory and regulation. Next little click. Yeah. And so what will happen is that prefrontal cortex is not regulating deeper brain structures, such as the anterior cingulate cortex, insula, kind of nerding out for a second. But that's in part what is creating a lot of the experiential suffering just in the biology. So what we want to try to do is how do we re-regulate that? Next slide. So this was some imaging done by, this is SPECT scan, so SPECT and PET, or actually this is PET scan, but PET is very similar to SPECT. But I just wanted to show you this image, what the red circle is, or the front part of the brain. And on the left side, you can see some people without depression, and that you see much more the yellow-green color. This is activation of the brain. And on the right, you see people with depression, and you can see their brain is not as active. And Mark George, who is a professor here at MUSC and has pioneered a lot of the work with TMS, he saw this, and the guy down the hall was using this magnetic stimulator, and he was putting it on people's spine. And Mark was like, well, what if you put it on your brain, you know? And the guy was like, why would you do that? So that was the beginning, kind of a lucky coincidence, if you will. I don't think it's a coincidence, but to engineer a new way to treat the brain. Next slide. So when we think about biology of the brain, we commonly think about the brain chemistry, right? We're thinking about medications and things that change the chemistry. But it's really important to say the chemistry is just changing the electricity. It's basically just changing how neurons choose to fire together. And so it's just changing, if you think most of it is like electrical circuitry with like little chemistry at the ends, right? And so we're giving people medications, and I'm a psychiatrist, I'm pro-medication, but it's going all through the body and it's hitting all kinds of receptors, where this is like a direct pathway to stimulate specific circuits of the brain involved with specific disorders. So I tell people, people ask, what do you do and stuff. I generally tell people I'm a brain electrician rather than a psychiatrist, because it's more fitting, because they want to talk about something else. I'm like, oh, I do this over here. And it's more circuit-based. Next slide. So I'm going to be talking with you guys about a variety of technologies, mostly about what's called TMS, and I'll explain what that is, but a whole host of other things, ECT, a little bit about vagus nerve and deep brain, some home devices that have just been FDA approved for treatment of depression, and then there's a whole host of other emerging technologies. So our last talk, there was about lasers, and then there was the photoacoustic. We're actually starting to use ultrasound. So just like you can use ultrasound to look at organs in your body, you can actually also use ultrasound to stimulate circuits of the brain. So that's going to be really cool. Next slide. I forgot to stare at Joel. There's a side note. There's somebody in the front, I'm just going to call it out, that he asked me not to stare at him the whole time. And I realize I'm doing a really poor job of that, so I'm going to work a lot harder at it now. right? So TMS, or transcranial magnetic stimulation. So what we're doing is taking the magnetic strength of an MRI. You've seen those big donut MRIs, and we're putting it in a spot about that big, and then we're putting it on specific areas of the head to stimulate circuits of the brain. So we run electricity through that magnet. It runs an electromagnetic pulse. It pulses, it goes through the skin, the muscle, the bone, and touches the brain and activates brain tissue, which is pretty cool. Next slide. And it has the field strength of about a 2 Tesla, which is pretty strong magnet, and it produces an electric current in the brain that you can't feel. I tell patients, if you took the top of my cranium off and you touched my brain, I can't feel a thing. There's no sensory neurons. So people don't feel it. They feel it going in on the skin, but they don't feel it touching the brain. We're usually going after this, what we call left dorsal lateral prefrontal cortex, which essentially just means on the top and the left. And what's also cool about it is you can use different frequencies. So you can use high frequency to activate neurons, and that's typically what we're doing in depression. But you can also use low frequency to inhibit neurons. So for example, if I put a TMS coil over Broca's area of my brain, which is involved with speech, and I put it in an inhibitory pathway and you made me count, I would start counting. I go 1, 2, blah, blah, blah. Like you can make a temporary aphasia in speech. So I try to tell people that are getting treatment with TMS, always tell your doctor when you had it, because this technology is changing fast. And this is like an engine. And what can you do with an engine? You can put it in a car, a boat, plane, use it as a generator. You can do all kinds of cool things, right? We're at the beginning of this. It's so exciting. So, and the idea that we're then not only stimulating these circuits, we're helping reshape the brain through what's called neuroplasticity. So this is a very potent way to induce neuroplasticity in the brain. Next slide, please. So conventional TMS, I will say less than 1% of people who meet criteria for TMS actually receive it. So part of this is an awareness problem. It's FDA approved, it's covered by most insurances, and less than 1% of people get it. With conventional TMS, up to 62% of people will get out of depression. Up to 83% respond, which means half of the symptoms have gone away. It's a targeted treatment with lasting effects. I always try to break up a little bit of like getting too clinical and heady. I got a note from, I just took a picture of the note from a patient of ours who got treated. She actually has written several notes, but this was just a thank you note. She says, and she's 18. She says, "Dear TMS, I want to thank you for how much you've changed my life. I would not be alive if it wasn't for you. I'm able to do so many amazing things and have new opportunities, all thanks to you. Thank you for helping me to keep on living. Love," and then her name. She told me that she was 17, I think, at the time. She told me that she was pretty sure she was going to die at 16, and she overdosed on medications and considered it a failure that she didn't die. And so she had lots of medications and therapy and you name it, and just she needed activation of her prefrontal cortex. And now she's going to be going to Clemson next year and doing biomedical engineering, because she was like, wow, this medical technology saved my life. I want to help create stuff like this too. Be cool, right? So we don't just keep people out of the hospital or make things less expensive. It's like we change people's lives, and then they can flower and flourish. Next slide. It's a mission, y'all. It's a mission. So TMS usually involves the conventional TMS, daily treatment, usually about 20 minutes, 5 days a week for about 6 weeks, plus a taper. there is a very rare risk of seizure, but there's more risk of seizure with medication. So most people are not worried about taking medication and having a seizure. Thinking and memory are unaffected, and people can continue outpatient medicines. There is some data that suggests the combination may be more effective. Next slide. This is an image of me with my first fellow. So we have donors that pay for fellows because the national education system hasn't deemed it useful to train people at a high level of proficiency. But here at MUSC, we have people that know it's important, and our hospital system, our health system supports it, and our donors support it. And I didn't have any gray hair then. Wow, that was amazing. Wow. So this is what's called more of a superficial TMS. It doesn't go as deep and wide in the brain, but it's great. Next slide, please. This is a form. There are different kinds of TMS. This is what's called deep TMS, so it goes a little deeper and wider in the brain. You can see this whole network of magnets that go in the brain, and you can see that red line. It goes a little deeper and wider into the brain, which just makes me think of a story. I was like early into doing TMS, and I remember one of the first patients I ever treated with this deep TMS device. And this lady, so we treat young and old, right? It's amazing. And this lady was maybe 70. And the older I get, that feels younger and younger. But anyway, she was she said, she was like maybe a couple weeks in, and she was like, I think I'm feeling better. And I was like, wow, well, that's great. So we're going to do 6 weeks of treatment. She's 2 weeks in. I says, how long's it been since you felt better? She says, it's been a long time. And I go, how long? She's like, well, since my daughter was born. And I was like, well, how old's your daughter? And she said, 43. So that's what I get to see in my clinic. This is part of my passion. This is God telling me where to be. I'm just doing what I'm told. Next slide, please. So some of the initial work with TMS, there was this trial by O'Riordan in 2007, published in 2007, showing response and remission rates, 24% and 14% remission rate. Next slide, please. Yeah. And it's kind of a busy slide, but just to kind of point out, the big, long blue bar is by Carpenter, was a real world study where they said if people know they're getting treatment compared to sham, people are getting real or fake TMS. If people are getting real TMS and you're coming into clinic and there are people that are being supportive and kind, how do they do? So in this instance, about 50, I think it said 58% remission rate. There's a whole host of studies that kind of point out that TMS is effective and better than sham. It's really important to do methodical science about these kind of things, because it's really important that, particularly as we go to scale treatments for people, we need to know if it works, because we know loving somebody helps a lot. So on top of that, what is actually changing? Next slide, please. And in some of the deep TMS, this is off their website, 20 to 30 sessions, 40 to 50% remission rate, meaning people no longer meet criteria for major depression with this conventional TMS paradigm. And these are things we do at MUSC. Next slide, please. And so I didn't dig into all the randomized controlled trials here, but we've had 4 very large trials showing around a 37% remission rate. I mean, we want it to be 100%. This is back in the early 2000s. And this is in people that have a less than 6% chance the next medication will work. So we have to put it in perspective. But in real world data, up to 83% of people are markedly better, and they have durability, for many months to years. Next slide, please. We also know that more is better. And And that's not always true in things in life, but we know that if you give people more treatment, you will have a better response. And they've even had studies where they show people getting, roughly 30 treatments, and maybe they haven't even responded yet. Like maybe they don't even look any better. And if you give them another 10 or 20 treatments, half of them will have a meaningful change. Like over 50% of their symptoms will go away. And that's been replicated in subsequent studies. And you can even predict, if you can even see a width of improvement earlier in, that they're going to like respond. So that's an important thing with this type of therapy. It's like having people stick with it, because if people wanting to feel better now, and it may take a few weeks, it may take a month and a half, it could take longer, but getting the treatment repetitively stimulating that circuit matters. And I think it matters more in people, almost like the longer somebody's had depression. Sometimes it seems like it takes a little longer. I think it's very interesting with TMS just got not only FDA approved for adults back in 2008, but last year got approved for adolescents 15 and older. And they're showing like 70% remission rates, right? I've treated kids with this type of TMS and some other types we'll be talking about called accelerated, and you can get people well in like 3 days. 3 days. So it takes awareness, it takes a community to change this together. Next slide, please. So a good question would be, how long does it last, right? And this is a durability of response curve. And so in the upper left, 100%, like you starting with people already better, what happens over 12 months? In this study, 62% of people are still doing really well. There's other studies that show about 70% of people are still doing really well. A good third have had a relapse. And you could say, well, what happens then? I think in that slide here, yeah, over 50%, depends on the study you look at, 50%, up to 80% of people will respond again. So we have people that get retreatment, and that's not a failure. Just like if you got pneumonia again, you wouldn't say, wow, I guess the antibiotics didn't work. You'd say, oh, you got pneumonia again, let's treat it, right? And I bring that up because sometimes we'll have patients that come in and feel like they failed. And I'm like, I know you're trying, your brain got a hold of you. That's not your fault. Let's help you get better. So we do retreat people as well. And some people even do some types of maintenance therapy where they may do some intermittent treatment because they might have a little dip in symptoms, and rather than wait until they've crashed, they'll get a little booster. Next slide, please. Yeah, this side effect profile, just to say that there are no like systemic side effects. So people could have like other medical problems, heart, lungs, joints, all kinds of stuff. We're just stimulating a specific circuit in the brain. There's no risk of cognitive impairment. Kind of the biggest thing is not having metal in your head, because you don't want to have magnetic metal in your head and then a magnet could move it. Most people don't have metal in their head, but some people do, right? So that's not maybe used to. If you kind of come see me or my team, we're asking, do you have metal in your head? And usually psychiatrists aren't asking that, but we do ask. Headache, the more common things people feel is the tapping sensation on the head as it's going through the skin, and then there's a little muscle twitching just during the time. Joel, I'm going to try to keep staring at you. I keep forgetting. I'm working on it. And about 1 out of 4 people can get some headache. It doesn't mean they always have headache, and it's usually like Tylenol, ibuprofen type headache. You can kind of treat that. There's actually even science that you can use TMS to treat chronic headache. So I'm here to mostly talk with you about TMS for depression, but it's FDA approved for OCD, smoking cessation. We're using it stroke rehabilitation. People have used it for negative symptoms of schizophrenia. We've actually done some research where at MUSC where you can push and pull the brain in terms of addiction. So you can actually use TMS to decrease craving for substances. We had a gentleman, just a side tangent, a gentleman that spent $60,000 on Adderall last year, and he decided to come in and see us for TMS because he figured that'd be cheaper. His insurance didn't cover it, but he figured he could afford it if he wasn't buying Adderall. And he had tears in his eyes by day 10. He's like, I don't even crave this a lick. This is amazing. So I bring these things up just because this is an engine, and we've got to get this out to the community at large so people know. Your own doctors don't know. So it's important. Next slide, please. People also like it. The patients that come in that have had horrendous side effects from medication, they're my favorite because they're not going to have that problem with TMS. So there's no systemic side effects. There's no sexual dysfunction. Some people take medications, it changes their sexual function. That's a big life changer. No kind of cognitive impairment, GI side effects, et cetera. Next slide, please. There are certain favorable features. So this isn't a treatment of last resort. I think sometimes people may think that's the case. We would rather catch somebody early. In fact, I would love for, in the future, that trying to pull towards us, we just do this first line, right? If it's already way more effective than medications. I did a talk last week at the National Behavioral Consortium, and it's for employee health and payers, and they can see it. They go, why aren't we doing this first line? I go, you tell me, right? It's just where we fund the dollars. Younger onset, no psychotic features, higher scores, anxiety comorbidity. Kind of the unfavorable is like the more things that haven't worked, or the next thing is less likely to work. But I always get amazed where I could have somebody come in who's failed everything, and it's like that was literally their problem, right? And you just, bam, they're well again. So amazing. And then there's some prediction things, so we can do some imaging of the brain and look at different connectivity patterns. I think I have a slide on that later, which we can predict how well somebody's going to respond. And we also can look at changes that occur to the brain after we've treated it. So next slide, please. We're on slide 29 of 80. Okay, so we'll just kind of keep track of if you need coffee, whatever. If you need to get up and stretch, it's okay. I'm kind of, hopefully you see what kind of guy I am. So anyway. There's a lot of organizations, the APA, CMS, VA, Canada. There are a variety of organizations at a high level that says this is an effective treatment and could be considered, first line, particularly, if somebody's not responded to antidepressant therapies. So next slide, please. And so if you were to kind of compare what we're talking about conventional TMS, these response rates, which again means at least half your symptoms are gone, and remission rates mean you don't meet criteria. If medications, particularly if somebody's had their second med or if they've had third or fourth, it's going to have about a 7% chance, but they have about a 15-20% chance it'll work. Conventional TMS usually about 30% or so. This form is not as good as ECT, which we will talk about. Similar to what you would see with ketamine, but it doesn't have cognitive side effects. People do TMS and they go to school, they work. I mean, we treat doctors and lawyers and teachers, you name it, right? So people are doing this treatment in between their schedules. And doesn't have any systemic side effects. It tends to last longer than pretty much anything else. And you can do it on an outpatient basis. So it's pretty favorable at scale to be doing this kind of stuff. I'm trying to get it scaled on the Earth, but I was talking with some folks earlier about we were looking at doing TMS in space. So we think about Elon traveling out into space. Are we going to take 1 billion Prozac pills, or could we take TMS machines, right? And so we were doing even studies with that. It's kind of interesting. Next slide, please. So kind of the punchline, this is TMS is a new engine. It's like a outpatient workhorse. We have high response and remission rates that last a long time. They're FDA cleared. It's clean. You're using the language of the brain more directly than chemistry. You're using electrical stimulation, and you're using the magnetism to kind of get through the skull to do that. It's pretty amazing. Next slide. So everything I just talked with you about is what I would call phase 1 of TMS, and most of the world doesn't even know about that. All right, but now I want to kind of move on to what we're doing in the future that's available now. So kind of second generation TMS involves this what's called theta burst stimulation. So it's basically more physiologically friendly, that you don't need as much time or energy to get the same effects. So instead of, I remember when I first started doing TMS, like when I didn't have any gray hair, you know, some people, if they had a high motor threshold, I didn't talk about this, but we find each person's brain dose. So you know how like with medications, it could be 20 milligrams or 40 milligrams, and everybody starts at 20 and then they go to 40? This is, we find your dose, right? And so some people would have a really high dose just based on their brain. It could take like an hour to get a whole treatment. Well, with the theta burst, you can do a treatment, depending on how many pulses you're doing, in 3 to 9 minutes, which is pretty cool. But what that really does is set up for what we call accelerated TMS. And again, in this 3D trial that was published in The Lancet, it was as effective as the conventional TMS. Next slide, please. So if traditional TMS is doing 1 session a day for 5 days a week for 6 or more weeks, what is accelerated? This is where we're not doing 1 session a day. We're usually doing, by definition, at least 2, but usually 5 to 10 sessions a day. We're doing more pulses and in a shorter period of time. So this is usually being done over days, not a month and a half. And it works, I would say, as effective or better. So we'll talk about that in the next slide. And so the third generation, which is this Saint TMS, was actually pioneered by some folks at Stanford who trained with us here at MUSC. So, and it was kind of beautiful to for them to come back to us at MUSC. We're the first kind of clinical site to be using this, and we're doing some ongoing research trials. But again, this is kind of the buildup of like thinking about, hey, let's take a look in the brain, right? And then let's look at how do we directly stimulate the brain using the currency of the brain, so this electrical patterning. And so people are getting an MRI. We're essentially using what's called functional MRI. So we're taking, rather than pictures of the brain, we're taking a video of the brain. And then humans are not, I'm just going to say it, not smart or computational enough to figure it out. So we run it through AI machine learning for 8 hours. So people could have a lot of charged positive and negative things about AI. This is a positive one, right? So we find the specific circuit for every person. So we already know how to find a specific dose, but with the conventional TMS, we know we're in the right structural area, but we don't know the right structural area for me or you or you or you. So with this, you can find the specific circuit, okay? And then instead of doing 1 session a day, we do 10 sessions a day. It's a long day, so we do 1 session an hour. Each session takes 9 minutes. And people are getting this, 1,800 pulses a day. It's like getting a month and a half of TMS per day. That's pretty amazing. Let's see, next slide, please. And just kind of show some of the imagery of it. So you can see the kind of what looks like an inverted or a horizontal 8, or what they call figure 8 coil, and that depressed dummy head. The depression can make you look so strange sometimes. I'm just kidding. But people have a tracker. So there's a tracker on their head, and there's a tracker on the coil. So, and then there's a camera. You see that arm with the little black cylinder-looking, well, maybe not cylinder, but it's a camera. So basically, it reads to the computer and says, this is where the person's head is. This is where the treatment coil is. We have the MRI to know what your brain looks like. We have the functional MRI and the AI that says, this is where to treat. And so, next slide, please. So we get all that arranged, and then, which is so cool, you just line right up on the area that you're supposed to be treating. I've done so much TMS. I've probably at this point been involved in about 30,000 sessions, directly or indirectly. And I could almost put TMS on somebody's head with my eyes closed, okay? I've just done it so many times. And what's interesting is we're always going after one structural area. And what I didn't predict is with this type of Saint TMS, this isn't necessarily the target for everybody. It's probably the target for a good third of people. And other people, it's over here on the side of their head. And other people, it's here on the front of their forehead. Didn't see that coming. But it makes sense to say there are different, not everybody's brain is the same, right? So of course, there would be different spots to treat. And so we have this rigorous methodology to not only find the circuit, but then say, how do I know I'm treating it? Really cool stuff. I mean, this is cutting edge. There's probably like, well, I don't know, maybe 2 hospital systems in the country that have this, that are using it and charging insurance. There are people who do it out of pocket, but this needs to scale. Get the word out, okay? Next slide, please. So this is an image of the time. So you can see this graph on the left. The black line at the top are people getting sham or fake TMS. And they don't know if they're getting it or not. And then the other group who are getting real TMS, they also don't know if they're getting it or not. But you can see this massive drop in what's called the MADRS, which is a depression score that's done by clinicians. And you can see this is over 1 week. This is amazing. 5 days total treatment, 2 to 3 days before people note initial symptom improvement. Last week I saw a lady getting, we were treating 2 people for Saint TMS, and her PHQ, I don't know if you guys are familiar with PHQs, but their PHQ score, it only goes up to 27. That's like, should you be in the hospital, right? That's scary. Her score was like 24, and when she came in for day 2, her score was a 5. So under a 5 is considered remission for depression. She looked amazing already. But people have a delayed perception of the change. Probably by end of day 2, day 3, she was just like, wow, you know, and she was like, well, this helped my sleep. And she's like, oh my God, I'm like sleeping through the night for the first time in 6 years, you know. Just profoundly, it's so profound to see this happen for people. I remember this, 2 people, think about a younger and an older person, was one person who, she was in college, but she had had depression for a long time and just really miserable and suffering and suicidal. Physician, her dad was a physician, and this treatment just totally saved her life. She went on, she was doing social work in mental health specialty, but just the gift. You know, when you give people their life back, right? You get them unchained, you get their brain unchained. They're immensely thankful, right? And it's an immense gift to be able to do that for people. There was another lady I remember, she's probably about 80 years old, had been suffering with this episode of depression for 40 years. And she was also one of these early remitters, like so by day 3, she was pretty much out of depression that she had had for 40 years. 40 years. And the way she told me about it was just blew my mind. She says, yeah, I remember like day 3 of treatment, I was remembering my mom. And I was like, why did you say that? She's like, well, my mom had really bad depression too. And my mom used to say to me all the time, I wish I was never born. I wish I was never born. And she was thinking about her mom. And she, in that moment, she raised her hands up. She's like, I want to live. She had tears in her eye. I want to live. So for me, day 5, what I'm doing is like, oh, what are we going to do with the rest of your life? How do we rebuild your schedule? What time do you go to sleep? What time do you get up? When do you go do yoga? When do you go to church? When do you get to see your friends? Like rebuilding somebody's life, right? But to kind of get the biological platform updated to do the other things. And this image just shows what we call pre and post. So you can see this is a functional MRI, so it is looking at regional blood flow. And the point I guess I would just make about this is there's 2 brain regions, kind of geek out a second, anterior cingulate cortex and the insula, and basically the pathological message and communication pathways in the brain reverse when you give people these kind of treatments, and you can see it, you can measure it. And that's pretty cool too, right? So we can also not only measure before and say where's the and predict, are you going to respond? We can find the particular circuit, and then we can treat it, and then we can see the change after, right? Isn't that amazing? Yeah, so cool. Woo! Next slide, please. So this was at MUSC, some of our data, and this was from last year. This is only a Medicare population. So what I would also point out that has changed, so currently Medicare AB covers St. TMS, and with some engagement with Blue Cross Blue Shield of South Carolina, they now cover St. TMS and regular TMS and TMS for adolescents. So just a shout out to Blue Cross Blue Shield of South Carolina, they're being progressive because they see it too. So my point about that is this isn't all comers. These are usually people that have had like depression for decades. It's a pretty tough group. Just hit the next thing and things should pop up. Yeah. And so kind of the punchline is 86% of people had a significant reduction in their depression in our sample. So 54% like literally knocked it out of the park. Another 32%, and that's like to the T. Like if you're missing by 1 point, we wouldn't call you a remitter, right? But it's totally changed their life, right? So to say you could treat these people that have been suffering for so long, and 80% of them thank you immensely as they start to reflourish and rebuild their life is a gift, right? Next slide. So just to point out, there's the saint is kind of like picking the targeting and finding this specific spot for everybody. There's another way to do TMS is like, we're actually not going to pick a spot. We're going to hit large parts of the prefrontal cortex. And so that's what we do with this deep TMS. And you can see that helmet has all these, it's like those are actually streams of magnets. And so that's the deep TMS. We already know you can do that 1 session a day for 6 weeks, but what if you did it faster? So they did a sample of 104 people. This trial led to FDA approval to do this accelerated TMS. And they wanted to say, does it work at least as well? So it's called a non-inferiority trial. Next slide, please. So what they did in the standard of care in this model, they did 4 weeks of treatment daily, followed by 2 sessions a week for 4 sessions. And they compared that to doing accelerated, where we're doing 5 sessions a day for 6 days. So usually over, say, a Monday through Friday. Somebody might do Monday through Friday, week 1, and then week 2 do one day. The goal is to get like those 6 days of treatment in over 2 weeks. And then they do a follow-up, come in once a week for a couple of treatments. Next slide, please. And what they had was, just really outstanding. 78% of people remitted from depression, 87% response, really high numbers. Took about 3 weeks, but people have been suffering for months or years or decades. This is amazing. and improve their quality of life, their work, their social life, their family life. You know, for people that have depression or family member, you realize it doesn't just affect that person in their brain, right? It hits the whole crew. It hits your family, your network. And so you're not just getting one person well, you're helping a lot of people. Next slide. Told you I was kind of cry, right? And I've been staring at you, Joel, at all, man. I don't know what's going on here. So at least what I'm trying to compel you to do is to think about, I'm not saying get rid of medications, but at least from a science-based view, if somebody has not responded to one or two medications, they're likely their insurance would cover them to do TMS. And where we're trying to go in the future is just do this instead, right? So you think about if you thought of cancer, right? Cancer, big deal, right? Imagine you had a life-threatening cancer and you had a chemotherapy agent that had a 79% chance to get you out of that cancer. Or you could try a chemotherapy agent that maybe had a 14 to 30% chance. And you got to try like 2 to 3 of those. Then you can try the 79% chance one. By the way, your disease may have progressed by then, right? How is this any different? This is part of the stigma, I would argue, is that if we would just go for the most effective treatment, and we know that's humane in other organ systems, and so we just got to get used to talking about brain health too. All right, next slide. So these accelerated protocols, which, I mean, any of this TMS is amazing, but these accelerated multiple treatments over several days really kind of changed the paradigm where people can take a week off of work or week and a half or something and get all this treatment in really quick. I see people come in with short-term disability that can become long-term disability. I would argue anybody getting short-term disability, why aren't they getting these treatments? Because we want to get people well and back to work. We want to get back to their lives. It serves an opportunity to treat underserved areas. Do you guys see that image up in the top right corner? Any guess of what that is? Mobile TMS, yeah, TMS in a van. So we're doing a study here at MUSC where we will go out to people in the area. We're usually going to MUSC primary care clinics, like because they got a place to plug in the device, and just reaching for the future and pulling it in. I'd like this to be available for people, and I want to put this TMS in schools, where kids are suffering with depression, and we can get them well fast. You've got to get the word out. I'm doing my part. Let's all do it together, right? You're doing your part, but we got to let people know. We have to let everybody know. Let your friends and family know. Let your doctors know. Let your legislators know. Let your insurance payers know. Let everybody know, because people don't know. Less than 1% of people get these treatments. If this was cancer, we'd treat it different. Next slide. So that's kind of taking most of the time to talk about TMS. Wow, 54 minutes. I gotta go faster. I did want to talk briefly about ECT. I know we were talking earlier about ECT, and some of the things you described, I've never seen, and I've been doing TMS for over 20 years. So the point I was trying to say to you is surgery's been around for a long time, and it's changed, right? It's safer and it's more efficient. Cars have been around for a long time, but the new ones are safer and more efficient. And ECT's been around for a long time, and it's safer and it's more efficient. And what we can do now that doctors didn't know back in the day is we can find brain-specific dosing. Just like we do with TMS, we do this with ECT. So we find the specific dose to treat somebody, and we massively reduce the risk of memory side effects with very high response and remission rates. Next slide. So what does ECT stand for? It's where we give small amounts of electrical stimulation to induce a seizure for therapeutic benefit. Most people should say, isn't that dangerous to have a seizure? And I go, well, depends. If you're driving a car or climbing a ladder, not a good idea. And right? In a controlled setting, though, that's just fine, right? We're in a controlled setting with an anesthesiologist, ECT-trained psychiatrist, and we really do save lives. I've had family members call the ECT machine the Lazarus machine, bringing people back from the dead, okay? I've had people misdiagnosed with dementias and all kinds of things, and they had a severe psychotic depression, right? So in addition to the depressive symptoms, their mind was playing extra tricks on them, right? They thought they had created evil in the world, that they were responsible. They thought if they were to eat, then people would die, you know? You couldn't convince them otherwise. And then you give them these treatments, and that all pops out, right? And we treat doctors and lawyers and teachers. It's not even a treatment of last resort. I would do TMS first, but if I needed TMS and it didn't work, I would definitely do ECT. I've done enough of this, and it's just amazing to save lives. Next slide, and probably some of these I'm going to go through a little faster just because I want to leave. How much time should we leave for questions, y'all think? 15 minutes? Okay, good. All right, so I got 15 minutes. Okay, throw the bread at me or something. Yeah, good. Joel, I haven't forgotten about you. All right, you actually told me not to stare at you, right? You had no idea I was gonna bring you up. Anyway, it's like a bit, right? It's super fun. So yeah, about 65% of people get out of severe depression with ECT. If people have a psychotic depression, it's usually 90%. It's my favorite. I don't want anybody to have that, but if they have it, let's do ECT if your meds are not working. About half of people do have a relapse into depression in 12 months. That's still less than what you see with medications. More targeted than medication, but less targeted than TMS. Next slide. It's usually about 6 to 12 treatments, average is about 10. We treat about 3 times a week. And we treat until people remit or they plateau. And a subset of people do maintenance therapy where they have had a relapse in a year, and we just retreat them. And we do say once a month or six weeks or something. And what I've seen for some people is it's like you buy people a window of time where now they have the energy, attention, willingness, and motivation to rebuild their life, right? So then they start working on their mind. What happened? They start rebuilding their relationships. They start looking at their ultimate orientation. They start re-engaging in work. Guess what? They don't need as much of this stuff. All right, next slide. So it's not a requirement at MUSC to wear your tighty-whities for ECT. People wear their clothes, okay? Regular clothes, just to kind of show where things go. There's an EEG on the head to measure brainwave activity. There's stimulating pads. There's EKG on the chest, IV in the arm. We give people an anesthetic to go to sleep for about 5 to 7 minutes. We give people a muscle relaxant, which I don't think your crew had. So people's body goes limp. And so when we're in a teaching hospital, so when we have residents or medical students see this, they go, oh, this is boring. I go, yeah, that's what we want. So we give people this treatment, and we're just watching their EEG, and then we watch the brain snuff out the seizure. And it's snuffing out that seizure. In this case, it actually also releases chemicals that change the circuitry, right? So it's kind of more of a diffuse way to do this treatment. And it's very safe. The seizure usually lasts about 30 seconds or so. And then they go to the recovery area for about 20 minutes. And let's see, it's probably time-wise. Let's keep moving. This is a side effect slide. I would just point out we haven't had anybody die at ECT. It's safe for the childbirth. Most of the risk is usually related to the anesthesia. People get headache or nausea, and you if they have those effects with anesthesia, which you can treat. People can get some memory side effects. Most of the memory side effects with modern ECT are related to anterior grade amnesia, which is a fancy term for like memory right around today or yesterday. So you might forget what you had for lunch, like most people don't, but some do. But there's good science that that memory will, their ability to have those memories fully recovers after people finish up their acute course. And it's important to say most people don't have those kind of things. Next slide. I would just also point out what's called bitemporal ECT, where we put the electrodes right here. Very effective to get people out of depression, but has the most risk of side effects. And that's probably the type of ECT you saw. We still use it, although it's changed a lot from even what you saw. We tend to use more of this right unilateral or this RAFT ECT, which includes research we've done here at MUSC. And so Harold Sackheim, who probably knows, if Mark George probably knows more about TMS than, and he's a professor at MUSC, knows more about TMS than probably anybody on the planet. Harold Sackheim probably knows more about ECT than anybody on the planet. Those are both professors here at MUSC. Pretty amazing. All right, next slide. So just to kind of put the tables here together, I'll just kind of point out you can look at remission rates, time to remission, treatment duration, and targeting. So you can see up at the top, standard meds having really low remission rates, 14% on the low end. You can see those remission rates climb as you do regular TMS, ECT, and these accelerated protocols have very high remission rates. And the Saint, I didn't point out some of the data, early data was like 90% remission rate. Time to remission, 2.6 days, 5 days of treatment, individualized targeting. Pretty cool. We gotta let people know. Next slide. I don't want to spend too much time on this because I realize I've already spent a lot of time. I want to talk about some other domains we haven't gotten to. I just would point out there are people who have chronic depression that like almost nothing works. And people can get what's called a vagus nerve stimulator. It's placed, we do it at MUSC. We did some of the first trials with it. It goes around the vagus nerve and sends signals up the brain. Next slide, please. And even Medicare saw that you basically up-leveled people's response rate. So if people, you looked at them not just over weeks or months, but years, so like 5 years of data, you'll see this jump from, let's say, treatment as usual, 40% of people are responding to treatment. It goes to 68 with a vagus nerve stimulator, or say maybe 25% of people remitted from depression over 5 years with treatment as usual, which is like meds and therapy. It goes to 43%. So next slide. They did, I don't want to go too far on the study, just in the interest of time, but Medicare has invested a lot of money in this technology. Next slide. And what we see is that even over a couple of years, that 80% of people, so about 4 out of 10 people meet criteria for remission at some point with vagus nerve stimulation. 7 out of 10 or 70% meet criteria. I like stats, by the way. 7 out of 10 people meet response criteria, and 80% of them kept the benefit. Because that's the other thing people sometimes struggle with, right, is that they might find something that works, but then it poops out. So this doesn't really poop out. Next slide. Just briefly mention this. Had 5 patients with epidural cortical stimulators. So this is like a pacemaker for the brain. And it's like having built-in TMS. And I have these patients, and I can change the programming with internal pulse generators, just like people have deep brain stimulation for Parkinson's disease to make the tremor stop. We actually have technology. I mean, I have patients with this. And it's like on a whole nother level to say you can just dial in and change dosing and keep people well. So interest of time, I'll keep moving. Next slide, please. There is a couple of technologies I would just mention briefly. One's called Flow TDCS and the other is Neuraleve. And these are both FDA-approved devices. I'm not going to dig into the studies here. They're not currently easily available. Like we have a few right now. There's no insurance covering this yet, but it's going to come. But that's like a whole other area, right? Rather than you come to clinic or the clinic comes in the van to a clinic near you, this is just something you can do at home. So stay tuned. This is technology available, but we got to get it affordable. Next slide. So just thinking about precision neuromodulation, you could think first-line treatment with TMS. If you need a more rapid response or robust response, you could look at things like SAINT. More severe urgent psychosis, catatonia, where people are frozen, can't move. Think about ECT, and then you could think about vagus nerve stimulation for the long haul. So I think of this as a whole platform of tools. It's not just one thing. It's like a whole way of thinking about treating the brain. And we're going to add ultrasound to this. It's just, stay tuned. It just keeps going. Next slide. So if people are not doing well with medications, having suicidality, severely impaired with functionality, they should be looking at these treatments. Next slide. I want to shift gears a little bit. And I got, 10 minutes. Tight. All right. So we talked about the brain. We said there's the psychosocial, spiritual. So at the psychological level, I don't know if you've ever encountered this yourself. I definitely see it in patients. Have you ever woken up first thing in the morning and you actually feel okay? And then you have a thought about the hellacious day ahead of you? And you start to feel tight and you start to do this and do that. This is all your mind, right? In severe depression, you don't have a choice. It's just, the brain has been told to behave a certain way and it's going to co-opt your mind. But if you're not in bad depression, you can shift your mind. And it's important to say there's what's happening, and then there's our interpretation of it and the story behind this interpretation. And in psychotherapy, really good psychotherapy, we start to look at the stories we tell ourselves and say, is it true? Right? Because we commonly are living from stories that aren't true. They're things we learned when we were young. Things we say, oh, you're not good enough, or you got to do X, Y, or Z to be of value. That's a lie, right? And then you have all these compensations. So next slide. I'll just kind of point out that even the science of it, people can use biological therapies to get out of depression, but there's studies where you can use psychotherapy and reduce the risk of a relapse of depression. You can reduce over 12 months, reduce it by 40% if you did psychotherapy after. So people get treatments like TMS or ECT, and that's when I'm trying to refer them to psychotherapy, not before when they're so sick they can't even think out of a box, It's kind of cruel to do that. I want you to change everything. You're stuck, right? Get the brain unstuck. Then you have the neuroplasticity. Then you use the psychotherapy to help shape what's shapeable now. And even in people who have more severe recurrent episodes, psychotherapy works. So next slide. And I'll just kind of point out the kind of different types of therapy, mindfulness-based, cognitive behavioral therapy. There's 400 different types of psychotherapy, but they all work pretty good. There might be certain emphasis, I would say. I wish I had more time. I'd talk more about it. Next slide. I think in a very broad way is that the mechanics of therapy is we're trying to move from the inner critic, to calm, right? So instead of closed, rejecting, avoidant, blaming, controlling, how do we become more curious and open and loving and motivated toward higher valued states of being, right? And how do we learn to change our self-talk so we're not beating ourselves up? Does anybody ever beat themselves up with their thinking? Isn't that mental violence? Would you be violent to other people? Why are you doing it to yourself? Don't you deserve to not do that to yourself? Yeah, you do. You do. And we need some help to learn how to do that. Next slide, please. So now we get into the social. So loneliness is not simply being alone. It's a sense of this gap between desired and actual connection. I had a resident tell me recently, a resident psychiatrist, where from the outside, you'd say, oh, he's so successful, he's finishing, he's a doctor, he's going to do all this stuff. And he's not where he wanted to be in his life. And he's like, loneliness is, you could be around people and be lonely, right? Right? And the loneliness is not just social, it affects our mind, it affects our brain, and it affects our spirit. Next slide. And we know that at least half of Americans, adults, will report loneliness, and we know it has substantial health risks. It's like you'd be better to smoke a half a pack of cigarettes a day and not be lonely, right? Because it's about 15 cigarettes a day is the price we pay when we feel lonely. Next slide, please. And the people who feel the most lonely are the Gen Z, the 18 to 22. The world is simultaneously so amazing, but also kind of scary, right? We don't know what's coming. There's all these things changing, and our young youth don't know what to do, right? As adults, we don't fully know what to do, but I think probably the best thing is to have some vulnerability about that and say, we got a lot of problems, but we got a lot of successes, and the only way we're going to do this is together, right? I don't have to have all the answers, and you don't either. But together, we're going to have a much better chance of finding our way. Next slide. And just point out that this affects the brain, affects cardiovascular system, your immune system, inflammation. People get this prefrontal suppression, their HPA, their hypothalamus, pituitary, adrenal system gets overactivated. People have higher rates of dementia being alone. And you can see that front part of the brain. Do you remember where else we were looking at the front part of the brain? With depression, right? So next slide. So you can get in this nasty cycle where you have social withdrawal and you start to feel negative. So it's co-opted your mind. Nobody cares. So now it's co-opted your brain and your body. And then you don't have any energy or motivation to do anything. And you get stuck, right? And then you can just see it's creating a vicious cycle. So I love the things you guys are looking at in the community. I mean, so inspiring to say you guys are, this is part of a medical treatment you're doing. Next slide. And just to say, this social isolation has a price. So about 50,000 people died in 2022. Suicide death rates have increased dramatically. Every 40 seconds, somebody's dying of suicide on this planet. Big deal. Next slide. So if we see that social isolation is a treatable thing, then it is looking at how do we get more structured connection, peer support networks, and family strengthening. Next slide, please. Could imagine we actually do screening for loneliness. Imagine the future state we're trying to pull in. And we go through a whole series of getting people into group therapy and community care to address this. Next slide. And we could look at this both at the individual level, some talk earlier about cell phones and things like this, but also what we do at a public health level, how we design our cities and our neighborhoods, looking into anchor institutions like our libraries, our recreation centers, and our faith communities, right? They really matter. Like they have biological effects. Next slide. And kind of the last little set in my couple of minutes, just to really say our ultimate orientation matters in recovering our sacred value, learning to connect, reorient towards love and truth is really important. Next slide. So to me, and I had this experience, and I would have never thought of, it wasn't on my radar, but the right people at the right time and God in the right situation put love in my heart, and it hasn't gone away. And I just love everyone. I wish I could give that to everybody. So we let the love come into us. It wants to express in the world. We can learn to heal our hearts and heal our wounds. And we learn to love each other in the most profound way. We don't necessarily have to look at people to treat you exactly like you expected, because they're dealing with their own problems, right? And God didn't ask us to judge them about that. God asks us to love them, right? And love our enemies, and not love people based on are they my group or my color or my gender or my country. He said, love everybody, right? But it's hard to love everybody unless we've done our work. And when we do our work, and we have to do it every day and every moment, the love can come through. It wants to come through. It's begging to come through. For me, I had to get broken down before I could be rebuilt. Next slide. So that's kind of thinking about how do we get people to transition from fear to a love-based orientation. I was raised Christian. My wife is Jewish. People ask me what I am. I say I'm a love fundamentalist. I will say on a personal note, I have had a Christ experience that, for me, I can just speak for myself, is the closest, most personal expression of that love. But that love comes through in a variety of ways. It's just, to me, the fullest expression. But just, if we could be love fundamentalists, I think that'd be a good spot. Next slide. So basically, it is how do we make these shifts both in our mind and our spirit from kind of this constrained psychological trap, the I don't feel good enough, that most of us have learned that love is conditional, that there's something you got to do, there's something you have to earn. That's not true. That's a lie. God loves us all right now. It's like learning to get out of the way, get our blockages out so we can just receive it. Next slide. This one's a whole set of practices that I don't think I have time to talk about, but basically this isn't something, if people are interested, catch me later, but these are things we can practice and do, and we can learn to rest in God, we can learn to commune with God, we can learn sacred discernment, and we can learn what happens when our body and our emotions and our intellect align with Him, align with God. It's an amazing thing. Next slide. So you could imagine a unified model where we're using biological therapies to reopen capacity, that it's mean to tell somebody to do the other things when their brain is stuck. And we have all these cool technologies to get the brain unstuck. But then once we do that, we got to work on our minds too, right? And not only working on our minds, reconnecting our belonging and connection in our social systems, and also our ultimate orientation. And hopefully you're seeing, I'm from the clinician side talking about when somebody's already sick, and then you guys are also talking a lot about prevention, right? So how do we rebuild our spiritual communities? How do we rebuild intrinsic love and trust in each other? How do we learn to be vulnerable and say, I don't know all the answers. In fact, I don't know most things. But together, we're gonna do a lot more together than trying to pretend like I know, right? So next slide. So I'm going to skip this so we have questions, but just the idea you can do these biological therapies, social and spiritual. Next slide. So I just wanted to dedicate this lecture as well to the loved ones we've lost and to make their loss matter. You guys are awesome. Thank you. Feeling the spirit here. I love it. So questions, and I know I went a little long, but we got a whole range of things. I'm the brain electrician, but I'm happy to talk with you guys about anything, everything. So, is there any, you got a question?
Thank you. I'm curious about, does this help with ADHD or with dementia or any of those types of
So it's an excellent question. So I focused on depression because that's what we know the most about. But I again would say, think of this as an engine, right, metaphorically, and we could treat basically any condition that involves brain circuits that are over or underactive, we can treat. We're just at the beginning of how to do that. So in principle, any neurological or psychiatric condition that involves circuits over or underactive, we can change. So early to say for ADHD, we have it for OCD, smoking cessation. We use it for chronic pain. We stimulate over motor cortex to treat all kinds of different pain off-label. It's going to come for addiction, so it's already covered for smoking cessation, but studied in pretty much all substance use disorders, and you can push and pull the brain, so it's coming, yeah. And there's actually, I didn't have it in this slide, there is a device that stimulates the trigeminal nerve that is FDA approved for ADHD in adolescents, so yes.
Okay, you just touched on something else, the trigeminal nerve in adolescents. Okay. I noticed you said something, you mentioned the LGBTQ community, and I know a lot of times when we talk about electroconvulsive treatments, a lot of people think about getting rid of the gay, as we can say.
Uh-huh.
Is it just the treatment of depression, or is it the treatment of the sexuality?
Good question. So we use it to treat major depressive disorder, catatonia, where people are frozen or stuck, and various types of psychotic disorders. We do not use it to change people's personality. We do not use it to change people's sexual orientation. From just a pure human ethical level, that's not ethical. And from a spiritual level, that's not what he asked us to do. He didn't ask us to judge anybody. So he asked us to love our enemy, right? Love it. We could, yeah. So yeah.
Okay, I have a question. I have noticed a huge increase in PTSD, and I would like to know, are you seeing good and promising results with treatment towards that?
Yeah, so that's a great question. So TMS is being used to treat PTSD and depression. It's not FDA approved, and it's part of a much longer story, which means it's harder to get coverage for treatment for it. But that's coming too. Yeah, we'll get better at that. We probably need to combine it with particular talk therapy plus the TMS. I didn't even get into, we're doing some studies where we combine cognitive or like psychotherapy plus the TMS. So that's coming too. Yeah, there's some studies though that could be positive. Yeah.
So in reference to the TMS, when do you see that you being able to actively begin that? Because I think you said you're not ready for that yet, correct?
The TMS?
Yes.
I've been involved in about 30,000 treatments, so we're
Okay.
very involved. We here at MUSC, so our MUSC in Charleston, we have two places we do this, downtown and in Mount Pleasant, with some other areas opening up. But in Florence, it's coming. Baby, it's coming.
Coming? Good.
I'm trying to pull the future into the now much quicker, right? But yes, it's coming. It's coming. Yeah.
I have a question. I was wondering if the TMS was treated for autism and if you see any positive result.
So there are some studies looking at it in connectivity of the brain. It's a similar idea. It's not FDA approved. So it's hard to get insurance covered. But where I've found it more so is TMS for depression in people with autism, right? And I've had probably one of the wildest cases I had. I was treating this 16-year-old, and she was getting treatment for depression. She had autism, and an interesting thing happened. So as her depression got better, she was at school, and her family would tell me kids made fun of her, but she didn't even notice. And all of a sudden, she could notice. She's like, kids are making fun of me. And initially, she didn't like that, but I kind of pointed out, well, that's how you change your behavior, right? She was actually now getting the feedback of the way I behave or do. People socially interpret me a certain way. So now I can change what I do so they interpret me differently. So I think there's a lot more to do with that, but yes, I think in principle, we can treat all these things. I know we're kind of running tight on time. Is there any kind of maybe last question, or maybe we wrap the break?
Thank you. How do we make this more common knowledge? I work with first responders with post-traumatic stress injuries and can see this being a huge, how do we make it more accessible and understood?
I think it's an all hands on deck, right? So doctors like me that do these technologies have to talk with as many people as possible. People getting treatments for this have to talk with as many people as possible. Healthcare systems like ours, which we're doing a lot of that this year, got to get the word out. It's all hands on deck. You know, I've talked with insurance companies. I'll talk with anybody, right? Because I think once we all know, and then we look at the data, we're going to do things differently, right? So it's a group effort at this point. Yeah.
One more question. Her question made me think of this, referrals. So if someone wants to access your services, how do they, is there a referral process? Do you have to go through a?
Sure. So there's a couple of things. We have multiple routes all the way from I didn't have it on their slides, but a telephone number that people could call. We have commonly, people may be with a doctor or a therapist that refers to us. People in the healthcare system and use Epic in the MUSC system can actually send a ambulatory referral to brain stimulation. I would even take smoke signals. All right. Well, What's that?
Is there a long waiting list?
We've been the busiest we've ever been, and we're growing. So that's a function of I want to be as busy as we can and help as many people we can every day. So that's not a problem. We'll make it work. Thank y'all.
Yeah.